Let's run through the high-yield pattern split for Step 2 dermatology. We're looking at decision logic for presentations like a firm nodule, a mobile cyst with a punctum, a flaccid blister with oral erosions, or a tense blister in an older adult. We also need to recognize periumbilical blistering in pregnancy, trauma-induced blistering in a child, post-drug epidermal sloughing with mucositis, a febrile child with superficial shedding, sun-exposed fragile blisters, and diffuse hair shedding. This is exactly how you need to categorize these conditions on test day. To tackle this, we'll break things down into pediatric skin conditions, bacterial infections, inflammatory and allergic reactions, autoimmune and systemic links, and finally, patterns of hair loss. Let's get right to it. First up, pediatric skin conditions, specifically focusing on infants and those tricky look-alike rashes. When you're evaluating diaper dermatitis, always check the distribution first. Candida albicans is a yeast superinfection. It loves warm, moist environments, so it presents as beefy red, confluent plaques that actively involve the skin folds, and you'll almost always see those classic satellite lesions. Irritant contact dermatitis, on the other hand, is just simple skin breakdown from prolonged exposure to stool and urine. Because irritant diaper dermatitis is contact-driven, it distinctly spares the deep skin folds. Those areas just don't have direct contact with the wet diaper. The erythema matches exactly where the material rests. Treat it with a topical barrier like petrolatum or zinc oxide. Now contrast that superficial breakdown with trauma-induced blistering in a child. We're talking about epidermolysis bullosa, which is an inherited epithelial fragility caused by defect in adhesion proteins. EB simplex is the common one, causing friction-induced blisters on the palms, soles, and exposed areas. Thankfully, it usually heals without scarring. To diagnose it, you'd biopsy a fresh blister for immunofluorescence microscopy, and management is all about careful wound protection and supportive care. Moving on, consider an infant presenting with distinct yellow, greasy scales on the scalp. You might also see glistening, confluent erythema in the neck folds, axilla, or the umbilicus. But importantly, the baby has no systemic symptoms. What's the diagnosis? That's seborrheic dermatitis. It shows up with those greasy yellow scales on the scalp, what we commonly call cradle cap, as well as in postauricular areas and intertriginous zones. The first-line treatment here is simple reassurance, along with emollients and non-medicated shampoos. Next, how about a patient with diffuse, rough, dry skin that's been present since early childhood and heavily flares up during the winter months? That classic history points directly to ichthyosis vulgaris. You'll see diffuse dermal scaling and associated hyperlinear palms, all resulting from a filigran gene mutation. This mutation impairs the epidermal barrier, leading to a massive drop in skin moisturization. You'll often see it associated with atopic disease and keratosis pilaris. To manage it, advise long baths to help remove the scales, aggressive moisturization, and keratolytics like urea, alpha-hydroxy acid, or salicylic acid. Moving into our second category, identifying bacterial skin infections and differentiating those acute care presentations. You absolutely have to be able to contrast the sharply demarcated, raised edges of erysipelas with the flat, poorly demarcated edges of cellulitis. Erysipelas is almost always caused by Streptococcus pyogenes. It hits fast, and patients develop a fever early in the course. Non-purulent cellulitis, which can be caused by either S. pyogenes or MSSA, goes deeper into the dermis and subcutaneous fat. It's a more indolent infection, and the fever usually shows up later. Here's a massive high-yield clue for erysipelas. Because it's a superficial dermis infection, the external ear is a prime target, since the ear actually lacks a lower dermis. So, if a patient presents with a red, hot, swollen, sharply defined lesion strictly on the external ear, accompanied by fever and chills, erysipelas is your diagnosis. It rules out deeper cellulitis entirely. Now let's talk about blistering bacterial infections. The bullous form of impetigo presents with enlarging flaccid bullae and a collarette of scale, which is driven by staphylococcal exfoliative toxin A. Contrast that with non-bullous impetigo, which gives you those classic honey-crusted papules and pustules. But you also need to contrast localized bullous impetigo with staphylococcal scalded skin syndrome, or SSS. SSS involves that same exfoliative toxin, but it causes superficial epidermal splitting in a febrile child. You'll see generalized erythema, superficial flaccid bullae, and a positive Nikolsky sign. A major differentiating factor here is that the mucosa is spared, which is how you distinguish it from severe drug reactions like SJS. Treat SSS with antistaphylococcal antibiotics and dedicated wound care. Let's transition to inflammatory and allergic reactions, focusing on step-by-step management. For chronic spontaneous urticaria, meaning it lasts over 6 weeks, you need to know the exact escalation protocol. Most cases are idiopathic. Step 1 is a second-generation H1 antihistamine. If there's no improvement after 2 weeks, you step it up. Increase H1 blocker dose, add a first-generation H1 blocker at bedtime, add an H2 blocker, or add a leukotriene receptor antagonist. If all of that fails, you move to second-line therapies like omalizumab, hydroxychloroquine, or tacrolimus. When managing moderate to severe inflammatory acne vulgaris in women, hormonal therapy is incredibly effective. Oral contraceptives and spironolactone directly target those hormonal triggers. Oral contraceptives contain estrogen, which is anti-androgenic and puts the brakes on sebum production. Spironolactone works by blocking the androgen receptor and inhibiting androgen biosynthesis outright. These are your go-to options when the acne clearly flares premenstrually or localized heavily to the lower face and jawline. Let's look at pityriasis rosea. This classically kicks off with a single annular pink herald patch on the trunk, and then erupts into pruritic oval lesions following lines of cleavage in a Christmas tree pattern. 2/3 of these cases self-resolve, so your main job is just treating the pruritus with antihistamines. Now, you must contrast benign eruptions like that with Stevens-Johnson syndrome and toxic epidermal necrolysis. SJS and TEN are life-threatening. They present with a flu-like prodrome, painful erythematous macules, vesicles, epidermal necrosis, sloughing, and, very importantly, critical mucosal involvement. The timing is usually 4 to 28 days after exposure to triggers like allopurinol, sulfonamide antibiotics, anticonvulsants like carbamazepine, lamotrigine, and phenytoin, NSAIDs, or mycoplasma. We classify them by body surface area. SJS is under 10%, overlap is 10 to 30%, and TN is over 30%. Treatment means stopping the offending trigger immediately and transferring the patient for burn unit-style supportive care. That brings us to autoimmune skin and systemic links, treating the skin as a window into internal disease. Take vitiligo, for example. This involves autoimmune destruction resulting in the absolute absence of melanocytes, leaving behind sharply demarcated depigmented patches. The testable point is its high association with other autoimmune disorders like lupus and thyroid disease. We also need to precisely differentiate autoimmune blistering diseases. Pemphigus vulgaris is a massive one. It features painful oral erosions, flaccid bullae, a positive Nikolsky sign, and intraepidermal cleavage. The mechanism? It's IgG antibodies attacking desmoglein 1 and 3 in the desmosomes. On immunofluorescence, you'll see a net-like intercellular IgG pattern. Then you have bullous pemphigoid, which typically hits older adults, causing intensely pruritic, tense bullae. Here, anti-hemidesmosome antibodies attack the basement membrane zone, leading to subepidermal cleavage and a linear IgG or C3 pattern. Finally, keep pemphigoid gestationis in mind. It shows up in late pregnancy with intense abdominal pruritus, followed by urticarial papules and periumbilical tense bullae, and it uniquely spares the mucosa. Next is porphyria cutanea tarda, or PCT, which is heavily tested for its systemic associations. It is strongly linked to hepatitis C, HIV, and excessive alcohol consumption. Estrogen use and smoking are also established triggers. Remember, PCT is a spontaneous disorder, not an inherited one. To lock in the diagnosis, you'll check for elevated plasma or urine porphyrin levels, mildly elevated liver enzymes, and signs of iron overload. Clinically, PCT presents with fragile blistering and scarring strictly on sun-exposed areas, especially the dorsal hands, alongside vesicles, bullae, and dyspigmentation. Now, let's switch gears from blisters to identifying benign skin nodules. You need to know the differences between dermatofibromas, epidermal inclusion cysts, and lipomas. A dermatofibroma is a firm, non-tender, hyperpigmented nodule, usually under 1 centimeter, commonly on the lower extremities. The key diagnostic clue is central dimpling when you compress it laterally. An epidermal inclusion cyst is different. It's a firm, mobile, dome-shaped nodule with a central punctum. It contains keratin, might produce a cheesy discharge, and is prone to recurrent inflammatory episodes. Contrast both of these with a lipoma, which is generally much softer, deeper, and highly unlikely to regress or recur. Finally, let's round out the review with patterns of hair loss and identifying the root cause. You need to be able to differentiate the specific shedding patterns. Anagen effluvium is the reversible, rapid hair shedding you see post-chemotherapy. Chemo targets rapidly dividing cells, which directly impairs the anagen growth phase and causes immediate shedding. Telogen effluvium is different. It presents with diffuse shedding and a positive hair pull test, but it typically follows a major physiological stressor, severe illness, pregnancy, or significant weight loss. Then you have alopecia areata, which is a localized autoimmune attack on the hair bulb cells. It presents as completely painless, distinct, smooth patches of hair loss, classically marked by exclamation point hairs at the periphery. And then there's polygenetic pattern hair loss, or androgenetic alopecia. This chronic, progressive, patterned thinning is heavily influenced by dihydrotestosterone. In women, it typically spares the frontal hairline, causing diffuse thinning at the crown. In men, it primarily affects the vertex and temporal areas. For management, topical minoxidil is the mainstay for women, while men can be managed with either minoxidil or an oral 5-alpha reductase inhibitor like finasteride. Let's finish on benign senile purpura. This presents in elderly patients as multiple non-itchy, painless ecchymoses on the hands and forearms. It's entirely due to harmless, age-related vascular fragility. Since their laboratory coagulation studies will be completely normal, no further workup is required. Spotting these benign, age-related changes is just as high yield as identifying severe systemic threats.